Welcome to Chapter 10 on different approaches to measure and assess implementation outcomes. The learning objectives of this session are: describe an evaluative implementation research framework and its associated outcomes, including implementation outcomes. Describe different examples of implementation outcomes. And describe different approaches for measuring implementation outcomes. Implementation research is a type of study that focuses on understanding the factors and processes that influence the successful adoption, integration, and scale-up of evidence-informed interventions and policies in real-world settings. It seeks to identify barriers and facilitators to implementation, and to develop strategies for overcoming those barriers and promoting the uptake of effective interventions. Its ultimate goal is to improve the quality, effectiveness, and sustainability of health, social, and economic interventions and policies. The outcomes of implementation research differ from that of traditional health research. Implementation outcomes are the effects of deliberate and purposive action to implement new interventions. Implementation outcomes have three important functions. First, they serve as indicators of the implementation success. Second, they are proximal indicators of implementation processes. And third, they are key intermediate outcomes of health outcomes and impact. There are three distinct but interrelated types of outcomes: implementation, service, and client outcomes. Implementation outcomes focus on the success of implementing an intervention in a particular setting, and include measures such as adoption, acceptability, fidelity, implementation cost, feasibility, penetration, sustainability, and maintenance. They help to assess the effectiveness of implementation strategies and identify areas for improvement. Service outcomes, on the other hand, refer to the quality and effectiveness of the services provided to clients. Examples of service outcomes include the number of services provided, the timeliness of services, and client satisfaction with the services received. Service outcomes focus on the quality and effectiveness of the service delivery system or arrangements for implementing the intervention, and may be used to assess the impact of the intervention on the target population. Client outcomes, also known as outcome measures, refer to the changes that occur in the clients themselves as a result of the intervention. These changes can be physical, behavioral, social, or emotional in nature, and may include improvements in health, well-being, or quality of life. Client outcomes are often used to assess the effectiveness of an intervention in achieving its intended goals. In summary, implementation outcomes focus on the success of implementing an intervention. Service outcomes focus on the quality and effectiveness of the service delivery system or arrangements for implementing the intervention. And client outcomes focus on the changes that occur in the clients as a result of the intervention. For an intervention or a treatment to be effective, it needs to be implemented well. Therefore, implementation outcomes are prerequisite to obtaining desired clinical or service outcomes. Measuring implementation outcomes will provide advanced understanding of the implementation process, enable researchers to compare effectiveness of implementation strategies, and promote efficiency in implementation research. Starting with implementation outcomes, let's look at the first of these outcomes, acceptability. Acceptability is a multifaceted construct that reflects the perception among stakeholders that the treatment, service, practice, or innovation being implemented is agreeable or satisfactory. Acceptability should be measured based on the stakeholders' knowledge, perception, and experience of the intervention or treatment from various dimensions including content, complexity, or comfort. The theoretical framework of acceptability, TFA, consists of 7 constructs: affective attitude, burden, perceived effectiveness, ethicality, intervention coherence, opportunity costs, and self-efficacy. Each of these constructs describe different aspects of the measure of acceptability. For example, affective attitude refers to how an intervention beneficiary feels about the intervention. This may reflect their emotional reaction to the intervention, independent of whether the intervention worked or not. Perceived effectiveness, on the other hand, refers to the extent to which the intervention is perceived as likely to achieve its purpose, and may reflect an individual's understanding of the problem at hand and the mechanism of how the intervention works to address this problem. This may be independent of the individual's emotional reaction to the intervention. The TFA figure shows the description of the other constructs of acceptability. Zone example of measuring acceptability using the TFA is a study assessing the acceptability of public-private partnership in artemisinin-based combination therapy (ACT) provision for the treatment of malaria in Manokwari, Indonesia. The study demonstrated how to use TFA to assess the acceptability of introducing a public-private partnership strategy in malaria control. The authors explore the dimension of the intervention's acceptability, that is, the effective attitude, burden, ethicality, intervention coherence, opportunity cost, perceived effectiveness, and self-efficacy. The study highlights the importance of a balance between public health benefits and business issues in the implementation of the Partnership for Artemisinin-Based Combination Therapy (ACT's) distribution. Additionally, adequate incentives for participating should be provided. These factors will influence the high or low acceptability of the intervention among community pharmacies. Let's look at the next implementation outcome: adoption. According to Proctor, adoption is defined as the intention, initial decision, or action to try, or to employ, an innovation or evidence-based practice. Adoption can be measured from the perspective of the provider or organization. Wisdom et al. Identified 27 predictors of intervention adoption. These predictors can be grouped into 4 contextual level categories. These are external system, organization, innovation, and individual. A study by Arnold et al. Demonstrated how to measure school-based intervention on mental health issues. In this study, the authors used a qualitative multiple case study design to identify factors that influence the adoption of a trauma-informed, universal intervention by urban public school administrators during an efficacy trial. Semi-structured interviews were conducted with school administrators. Data on individual factors such as professional background and experience, organizational level such as leadership and policy alignment, and macro-level data, for example policy and financing, were assessed. The study concluded that individual, school, and macro-level factors each influenced administrators' decisions to adopt a trauma-informed school mental health intervention within the context of a school-based prevention trial. Let's now take a moment to discuss the second outcome under intervention outcomes: appropriateness. Proctor defines appropriateness as the perceived fit, relevance, or compatibility of the innovation or evidence-based practice for a given practice setting, provider, or consumer, and/or perceived fit of the innovation to address a particular issue or problem. To some extent, appropriateness overlaps with acceptability. Proctor, however, differentiates between the two outcomes, as an intervention may be perceived as appropriate, but not acceptable, or vice versa. For example, a treatment might be considered a good fit for treating a given condition, but its features, for example, rigid protocol, may render it unacceptable to the provider. Weber, in his article entitled, A Conceptual Review of Decision-Making in Social Dilemmas, applying a logic of appropriateness, argued that appropriateness is a measure of applying certain rules in certain situations, taking into account someone's identity. When measuring appropriateness, we should, therefore, measure whether the intervention is perceived as right, fit, suitable, reasonable, proper, applicable, or well-aligned. Similar with other implementation outcomes, appropriateness can be measured both quantitatively and qualitatively. We have discussed acceptability, adoption, and appropriateness. Let's take a look at cost. Proctor defines implementation cost as the cost impact of an implementation effort. The implementation costs vary because of these 3 components. The complexity of treatment intervention, the complexity of implementation strategy, and the settings where the intervention is implemented. Implementation costs are related to the development and execution of the implementation strategy. For example, costs of implementing collaborative care to improve depression treatment includes the costs of recruiting and employing case managers, costs of training psychiatric consultants, social workers, and other care staff, costs of installing information technology, and costs accrued to study sites for planning local strategies to implement collaborative care. Intervention costs are the resource costs that result as a direct consequence of using the evidence-informed interventions. For example, implementation scientists may seek to increase the use of tissue plasminogen activator for patients with ischemic stroke. In this case, the intervention costs are those associated with specific expenditure in the use of tissue plasminogen activator. The intervention costs increase with uptake, whereas de-implementation studies typically seek to reduce the use of an intervention and its related costs. An intervention cost should consider costs borne by patients, participants, and caregivers as a result of the intervention. Non-healthcare costs such as transportation or child care costs, informal care assistance and time need to be considered when calculating intervention costs. Researchers should estimate the intervention costs and implementation costs separately. Downstream costs happen after we have implemented the intervention and implementation strategy. These expenses could be the result of changes made intentionally, or the ones that happened accidentally, or unintentionally, because of the implementation plan. This can include healthcare utilization and costs, productivity costs of patients and caregivers, costs in sectors other than healthcare, and future-related and unrelated health and non-health costs. Let's now look at the next implementation outcome, feasibility. Proctor defines feasibility as the extent to which a new treatment, or innovation, can be successfully used, or carried out, within a given agency or setting. Feasibility should be measured when there is a need for establishing, increasing, or sustaining community partnerships. There are limited previous publications or evidence of a certain intervention. Before conducting a study on a specific intervention, without in-depth research or knowledge on the population's sociocultural beliefs, or without a diverse research team, or without a research team who are familiar with the setting and targeted population. The intervention target or population needs unique consideration. And finally, when previous interventions that used similar methods were not successful. Another framework that is often used to measure feasibility is the REAIM framework. REAIM is traditionally used to evaluate an evidence-informed intervention and implementation efforts, and this evaluation can in turn show whether or not the intervention is feasible in a given setting. REAIM consists of 5 constructs. R stands for Reach the Target Population. Reach is the absolute number, proportion, and representativeness of individuals who are willing to participate in a given initiative, intervention, or program. Reach can be assessed with multiple approaches depending on the phase of implementation, whether planning, implementing, or evaluating. E stands for effectiveness or efficacy. The impact of an intervention on important outcomes, including negative effects, quality of life and economic outcomes. The A in REAIM stands for adoption, by target staff, settings, systems, and communities. The absolute number or proportion, and representativeness, of settings, and intervention agents, people who deliver the program, who are willing to initiate a program. Adoption can be assessed at setting and staff level. I stands for implementation consistency, costs, and adoptions, made during delivery. At an organizational level, implementation refers to the fidelity to various elements of the intervention's protocol, including time and costs. At individual level, implementation refers to clients' utilization of intervention strategies. M is for maintenance, or sustainment of intervention effects over time. Maintenance refers to the extent to which a program or policy becomes institutionalized, or part of the routine organizational practices and policies. At individual level, maintenance is defined as the long-term effect of a program on outcomes after 6 or more months, after the most recent contact to the intervention. Feasibility can be assessed at different phases of developing and implementing an intervention. Fidelity is the degree to which an intervention was implemented as it was prescribed in the original protocol, or as it was intended by the program developers. The following elements can be used to assess the fidelity of implementation. Adherence, this includes content, coverage, frequency, and duration. Moderators, this includes intervention complexity, facilitation strategies, quality of delivery, and participant responsiveness. And finally, identification of essential components. Let's have a look at an example of a study assessing implementation fidelity. This study explores the implementation fidelity of hospital-based, directly observed therapy for tuberculosis treatment in Bhutan. The study used a mixed method study, combining a cross-sectional survey among TB patients and in-depth interviews with TB patients and health staff. All components of adherence to directly observed therapy guideline, coverage, content, frequency, and duration, and the moderating factors, which comprise intervention complexity, facilitation strategy, and quality of delivery, were measured. The study found that the key factors affecting poor adherence to directly observed therapy were unwillingness of the patient to visit hospital on a daily basis, due to long distance, financial implications, and lack of support from family and friends during treatment. We'll now look at penetration as an implementation outcome. Penetration is defined by Proctor as the integration of a practice within a service setting and its subsystems. For example, penetration among a group of family practices in a well-defined geographical area could be defined as the spread of an evidence-informed intervention or implementation strategy from one practice to another within that group of practices. It can also refer to the extent to which the evidence-informed intervention or implementation strategy is connected to other activities within a specific practice or group of family practices. Penetration can also be defined as coverage, though the term coverage is often applied to a population setting, as opposed to a service delivery setting. For example, the number of eligible individuals who use a service over the total number of individuals who are eligible for the service. The concept of penetration is similar to the construct reach in the RE-AIM framework. Reach is defined as the absolute number, proportion, and representativeness of individuals who are willing to participate in a given initiative, intervention, or program, and reasons why or why not. Let's look at an example of penetration to study the reach and effectiveness of mHealth in Ghana. The study was conducted among girls aged 14 to 24 in 22 secondary schools in Accra, Ghana. The mHealth intervention was an interactive, mobile phone quiz, in which participants could win phone credit for texting correct answers to sexual and reproductive health questions. 81% of participants engaged with the mHealth program, with no evidence that the program disproportionately reached better-off groups. The program was effective at increasing knowledge of sexual and reproductive health across all strata. Higher levels of engagement were associated with higher knowledge scores up to a year later. There was no significant impact of the program on self-reported pregnancy within subgroups. Finally, let us look at the last method or approach to studying implementation outcomes, that of sustainability. Sustainability is defined as the extent to which a newly implemented treatment is maintained, or institutionalized, within a service setting's ongoing, stable operations. There are 9 elements that influence the sustainability of an intervention. These are funding stability, political support, partnership, organizational capacity, program adaptation, program evaluation, communication, public health impact, and strategic planning. To be able to measure these elements, we may need to use a mixed method study, combining quantitative and qualitative methods. Let's look at an example of a study to assess the sustainability of polio immunization in the health system transition in Indonesia. This is an example of how a competing priority posed a significant challenge to sustaining the government's commitment to polio immunization and AFP surveillance during the transition toward a decentralized health system in Indonesia. Additionally, variation of local government capacities has also affected immunization delivery and commitment at the subnational level government. Moreover, while the decentralization reform led to a more democratic society, it also facilitated vaccine rejection and hesitancy. Therefore, a multi-sector partnership played a significant role in addressing these elements and in maintaining polio immunization coverage. As previously mentioned, implementation outcomes can be measured using quantitative methods, qualitative methods, or mixed method approaches, which combine quantitative and qualitative approaches. Different levels of outcomes measurement exist. These are individual, organizational, and setting or society outcomes. Let's summarize what we have learnt in Unit 1 of this chapter. Implementation research is a type of study that focuses on understanding the factors and processes that influence the successful adoption, integration, and scale-up of evidence-informed interventions and policies in real-world settings. Implementation outcomes have three important functions. They serve as indicators of the implementation success, they are proximal indicators of implementation processes, and they are key intermediate outcomes of health outcomes and impact. There are three distinct but interrelated types of outcomes: implementation, service, and client outcomes. Implementation outcomes focus on the success of implementing an intervention, service outcomes focus on the quality and effectiveness of the service delivery system or arrangements for implementing the intervention, and client outcomes focus on the changes that occur in the clients as a result of the intervention. That's it for this chapter, but before you go, take a moment to consolidate what you have learnt by putting it into practice. Download this chapter's supporting resource material and complete the activity there. Once you have completed the activity, please join us for Chapter 11.